Hello, everyone, and thank you so much for joining us on our first ESOR Sustainability Online module. I'm absolutely thrilled that we've been able to kick off this bite-sized lunchtime course, a series of webinars that will go throughout the year on different topics focused on sustainability. Each of the sessions comes with one CME if you do the course evaluation at the end. I think the course will be very important as part of the toolkit for those that will be taking part in the ESR Green Imaging Department scheme. Today, I'm joined by two speakers. We are joined by Dr. Sarah Sheard. She is the chair of the ESR Sustainability Subcommittee. And I'm really delighted that she's here with us. She's spearheaded a lot of important actions for the ESR, many of which are now starting to come to fruition. So we're going to hear an overview about sustainability in radiology from Sarah, who will kick the whole series off. And then we'll have a study from Matthias Chodorowski. Dr. Matthias Chodorowski is a radiologist. He's head of clinic and head of ward at the Centre Hospitalier Laderneau Ferdinand Graal. That's in Brest, in France. He's a member of the Ethics and Sustainability Group of the French Society of Radiology, and he's been working in sustainability throughout his internship, working on subjects such as contrast media management and energy consumption. I just want to give a nice call out to the French Society of Radiology, who are really very early adopters of sustainability practice and advocacy from the society, who developed a white paper back in January 2022. So without further ado, I'd like to ask Sarah to share her slides and we'll get started with the session. Thank you very much, Sarah.
Thank you so much, Andrea. If everyone will just bear with me for a few seconds while I just get my slideshow sharing. So then I think I can put it into... Oh, hang on. Oh, base. And then... Right, can I just confirm that you can now see my slideshow in slide view?
Yeah, it looks great.
Perfect. Thank you so much. Lovely. Hi, everyone. I'm so delighted to be here presenting the first talk as part of this series. So my talk is entitled Sustainability in Radiology, a Path to Greener Healthcare. So hopefully I'm going to take you all the way through from the very sort of basics of why climate change is important to health, just a little bit about actually what is climate change, because I don't think everyone necessarily has sort of been taught the basics. I certainly hadn't when I started this. And then all the way through to specifics to radiology and what we can do in radiology to improve our sustainability. Please just put questions in the chat and we'll try to answer as many as possible at the end. So the World Health Organization has stated that climate change is the greatest threat to human health. The reason for this, I've taken this graphic you can see on this slide from the WHO website, and it's quite a nice sort of explainer about just how this actually happens. So climate change causes extreme weather events, high temperatures, poor air quality, poor water quality, and difficult poor quantity of water, so difficult access, has issues with in terms of agriculture, with food scarcity, and also vector ecology, so mosquito-borne diseases, etc. All of those things will change as the climate changes. There are different groups of people who are going to be more vulnerable to these, particularly depending where they live, underlying health conditions, access to healthcare themselves. But climate change is also actually going to put stress on the healthcare systems themselves. And so then you can see at the bottom bar just some of the health conditions which will be a direct result of climate change, and they vary from respiratory illnesses, like I mentioned, vector-borne diseases, diseases of poor nutrition, etc. So they have said that between 2030 and 2050, climate change is expected to cause approximately 250,000 additional deaths per year from these diseases. Just to talk a little bit actually about what is climate change, what is global greenhouse gases. So the basic premise of climate change is that human activity, which mainly burning fossil fuels, is causing the release of gases into the atmosphere, which cause the sun's heat to be trapped in a similar fashion to a greenhouse used in sort of gardening and agriculture. So according to the Kyoto Protocol from 1992, there are 7 main gases or groups of gases, which are just listed. I'm just going to put my pointer on, just listed in this little box across the top here. So there's methane, nitrogen dioxide, sulfur hexafluoride, carbon dioxide, which everyone will be familiar with, chlorofluorocarbons, which is a group, perfluorocarbons, and hydrofluorocarbons, so 7 gases or groups of gases. Each of these different gases have a different potential to cause global warming. And carbon dioxide is sort of used as the unit, which is why you may be familiar with seeing this carbon dioxide equivalent notation. So carbon dioxide actually has the lowest global warming potential of all of these, but is by far the sort of highest emitted greenhouse gas. But if you look at this table that on this slide, you can see that I've put that methane has a global warming potential of 25, so 25 times greater. One molecule of methane has 25 times more global warming potential than carbon dioxide. Similarly, nitrous oxide has got 298, and some of the F gases, so the ones containing fluoride, are up to over 22,000 times more global warming potential than carbon dioxide, but they only make up about 5% of emissions. I've just sort of put these gases on particularly because some of them are present in pharmaceuticals, particularly in inhalers, and propellants, and also anesthetic gases. So desflurane, which is quite a commonly used anesthetic gas, and an F gas has the global warming potential of 3,714. And in the UK, a few years ago, some work was done and it showed that it accounted for about 2% of healthcare emissions, but it can be phased out and replaced with gases with lower GWP. So just thinking about overall impact of healthcare. So we have this very difficult paradox that whilst climate change is impacting human health, actually globally, healthcare itself has a huge environmental impact. On a global scale, it's thought to represent about 4% of greenhouse gas emissions. And then obviously we mustn't forget that as well as greenhouse gas emissions, there are other environmental impacts. For example, we use a lot of resources from raw material extraction, but also we generate a lot of waste that either has to go to landfill or be incinerated, and we pollute the water streams. We'll touch on that a little bit later on. In higher income countries where we have much more developed health systems, we tend to have a much higher carbon footprint, and it's estimated to be up to about 10% of the national emissions in the United States. I think it's a little bit closer to about 6 to 7% in Europe, depending on the country. So I've just put some graphics here from the UK. The UK National Health Service has made some commitments to reaching net zero by, I think, 2030 in certain scopes of practice. I've put this up because when I started looking at the environmental impact of radiology several years ago, and there was so little research done, I said we just needed to some basic information about healthcare just to start to even try and decide how we were going to approach this, what we should be thinking about the most. And this is a really useful graphic because it just takes healthcare as a whole in the National Health Service in England and breaks down what the different sort of contributors to the overall emissions from the operations are. So you can see here, I'll just put on a few. So around the edge of this graphic, hopefully you can see the buildings, the hospitals using energy, that's about 10%. Water and waste, about 5%. So the anesthetic gases and inhalers, like I mentioned, about 5% there from those F gases, because whilst the volumes are small, the global warming potential is so high. There's business travel, there's patient travel, there's staff travel, visitors traveling. And then you can see sort of some of the procured services, so things that aren't manufactured but are purchased and used by the health service. So medical equipment, medicines and chemicals all fall into this blue area, which is obviously very much the highest percentage of contributors. So none of this was radiology specific. There was this nice little graphic here where it was possible to go around and identify some of the things that we were doing, which was very helpful. So let's zoom in on radiology now and try to understand what the impact of imaging is. So I often present this paper. It's from an interventional radiology group based in New York, and it was published in 2021. And they did this life cycle assessment of operations in interventional radiology. So the graphic might look a little bit confusing, but I think it's just a lovely depiction of how we can lay out what goes on and analyze it. So in this graphic, the group wanted to look at the environmental impact of an interventional radiology procedure in their hospital. And so when they were deciding how to measure this, they produced this graphic. So we have here on the black line that hopefully my pointer is showing the sort of boundaries of the project. So the patient travels in on the left side and the patient emerges at the end of their procedure on the right. Along the top, we have the resources that are going into this unit. So we have staff travel, electricity, anaesthetic gases, linens. And at the bottom, the waste from the procedure is coming out. So sharps and the laundry from the linens in the interventional procedure room. And then inside the box, we have the intake room, so the anaesthetic room, for example, the procedure room where all the imaging equipment is housed and the procedure takes place, and then the recovery room. And in each of these, you can see all the resources that are being used that will contribute to the overall carbon footprint of the case. And then we also have the control room here, where the sort of computer screens and electronics, etc., are housed. And so this is the results from their study. So they took 1 week of daytime procedures in their hospital, in their interventional radiology department. When they looked at the cases that had taken place, they were quite satisfied that it was quite a representative mix of their normal practice. The things they didn't count, and I'll just go back again, were the patient travel to and from the hospital, which I guess is generated by the procedure. They also didn't look at any post-procedure care the patient needed after they were sort of finished after they left the recovery room. But what they found, and hopefully you can see these red boxes here. So the one I'm just pointing to here, the HVAC, so heating, ventilation, and air conditioning systems in the interventional suite accounted for 49.2% of the total greenhouse gases from the procedure. And then the next biggest contributor was the single-use disposable equipment as part of the procedure, so medical and non-medical. And if we go down here, just wanted to point out that actually the power consumption by the imaging equipment in interventional radiology, which obviously may use slightly lower energy than some of the big machinery like MRI scanners, but still it only accounted for less than 3% of the greenhouse gas emissions from an interventional radiology study. So just to take a similar, so I've just produced a slide just to take a similar view, but to sort of zoom out a little bit and take a more general view of radiology. This is basically a similar slide. So I have taken the journey from the very moment up in this top left-hand corner when a referral is generated. So a clinician decides that their patient needs an imaging test. So that referral comes to the radiology department, and the radiologist assesses the request, decides if it needs to be done, and protocols the study, so decides what imaging test needs to be done, if there are any contrast required, etc. And I just want to sort of emphasize that this is a very, very important point, because if at this stage the radiologist decides the scan's not indicated, or has a look and discovers the patient had a test only a few weeks ago, which already answers the clinical question, then none of this needs to happen at all. And all the environmental impact associated with everything in this big black box here doesn't need to happen. So removing low value imaging and making sure we're not duplicating tests is by far the most important thing we can do to reduce the environmental impact of radiology. Sorry, just have a drink of water. So once the radiologist decides the patient does need the test, the patient then travels to the hospital, hopefully by public transport, but often by car. And once they're inside the hospital, then all the environmental impact, so the emissions and waste, etc. So we have the energy required to run the hospital, we have the power and the air conditioning and the computer sort of infrastructure required for the imaging equipment. We have consumables, so we give contrast, we need plastic tubing and all of paper, bed covers, etc. And then we must, some of the things that are a bit harder to consider, but we mustn't forget, is that there's an environmental impact of reporting through running the reporting room, which has lots of high energy monitors and requires, again, the air conditioning systems, and then the storage of the patient's imaging, which can be for a long time, and I'll speak about that in a little bit more detail. And then finally, this test might generate downstream investigation, or so the patient needs a follow-up scan, or we've seen something and want to request a different test for an incidental finding, and all of that also needs to be considered in light of the environmental impact. So again, just thinking about what was missed, what wasn't included in that interventional radiology study I've showed you about. This is some work we've done at Imperial on the environmental impact of having a CT scan in our hospital, but we have included the patient's journey to hospital. And we found that you can see the dark blue section of the chart, that actually about 60% of the total emissions per scan were just for the patient coming to and from the hospital. And this is sort of proportion of contribution from travel to the hospital is backed up by a study from a group of physicists in the radiotherapy department in Manchester in the United Kingdom, who looked at external beam radiotherapy and found while the equipment's a little different, and there are differences, there is roughly an equivalence to what's going on in the hospital, but they found that their patient travel accounted for about 70 to 80% of the carbon footprint. So again, just talking about whether patients actually need to come in for studies, I think is really important, and considering how it's delivered to them. So this is my slide on data storage, and it doesn't have very many figures on it because at the moment we don't really have a good understanding. It's a very complex world, partly because it's not something we understand very well, but it's quite difficult to get hold of data about it, but it's definitely a very big emerging area in radiology. I think the important points are that as radiology expands around the world, we're seeing an exponential rise in the number of studies which are being stored digitally. Often we store multiple reformats, even though modern PACS systems can easily do reconstructions in multi-planes with a sort of basic data, but we're storing sort of all the different axial reformats. Often they're stored indefinitely. We don't have disposal policies for imaging in lots of countries. So this is likely to be a very significant contributor to radiology emissions, and hopefully we're going to start understanding that a lot more soon. I've said that the factors include the number of series saved, as I mentioned, but also storage location is very important, whether these are stored on site, whether they're stored off site or in cloud storage. I think that we're quite limited, partly because hospitals and healthcare systems don't necessarily have a deep storage or disposal policy, and there's lots of patient data rules in different countries, but also sorry, so yes, we're limited by national data storage rules in lots of countries. But we can minimize the emissions, even if we don't understand them too well yet, by optimizing the number of series stored. So really making sure we're just storing what we need to be able to reconstruct that in future. And then if possible, considering alternative storage options and thinking about whether we can dispose or archive imaging differently. And I hope this is something we're going to see a lot more of. Looking at waste, I thought I would just quickly show you a case study from a group of radiographers at Imperial College. Did a project a few years ago looking at the contrast giving set from CT. Because at the time, what was happening was the whole thing was being connected. So when the study was over and the bottle was empty, the bottle, the tubing, the connectors, and the patient cannula on the end were all just being disconnected and put into the sharps and infectious waste bin. And it's important to note that the incineration of the sharps and infectious waste is quite carbon intensive. So it generates 1.85 tons of carbon dioxide emission equivalent per 1 ton of waste. But actually, breaking down all the different components of this, the bottle was either made of glass or plastic, and both are recyclable. There were some issues with the labels, and so the team discussed it with the waste management department in the hospital and also with the downstreams waste contractors, and had a good discussion about how to deal with this. And they agreed that it was recyclable. There was no reason it couldn't just go into municipal recycling, but just to take the label off, just so that didn't cause alarm that it was a sort of pharmaceutical bottle. In many countries, a residual contrast recycling scheme is available. So if there's a little bit left that can't be used, it can be collected and sent back to the manufacturer and recycled. And then the sharps, the very last little bit, which deliver the contrast to the patient, can then go into the sharps bin. So by separating all these out, we were able to put things into municipal and specialist recycling, like I just mentioned. Some things were able to go into the non-infectious waste, which actually in this orange box has a negative carbon dioxide because they used energy from waste capture. And then just like I mentioned, the last little sharp bits, which were actually needed to go into that high intensity waste stream. So what they found is they could actually reduce the volume of waste into this high intensity stream by 98%, just through a bit of communication, thinking about how to do it, and then obviously educating the rest of the team. So I'm almost on my last slide. I quite like this slide. It's sort of simplifying down what are the biggest, what of our operations have the biggest impact, and what can we do to improve our environmental impact. There are lots of other things we're going to understand lots more in the coming years, but for now, number one is reducing unnecessary imaging. Like I mentioned, I think that speaks for itself. If you don't do the test, then you don't generate any of this these emissions and other environmental damage. If we can think about minimizing patient travel emissions, can we avoid them coming into the hospital sometimes through teleconsultation? Can we use satellite imaging facilities which are much closer to the patient's own home so they can travel more easily, shorter distances? And can we work together with our clinical colleagues so that we offer, so the patient only has to come into the hospital once and they can go to their outpatient appointment and they can have multiple tests while they're here rather than having to come back several times. As we saw from the interventional study, heating, ventilation and air conditioning has a huge impact. And if we can optimize this, so turning it down when we can, have rooms that are sort of smart so that when the imaging equipment powers down, the air conditioning can power down too. And also trying to make sure we are educated about switching on and off systems and working with vendors and engineers, it's supposed to say there. Just have the discussion about what is possible. Minimize single-use items is quite difficult, but there are methods to do this. Reusable instruments, drapes and gowns. And then when we do have single-use items, for example, in that waste, in the contrast study I just showed you, thinking about appropriate disposal of these. And then finally, I think data storage we're going to see a lot more talk about recently. I think there are hidden depths to this. There are obviously lots of ethical and clinical and legal considerations to how we store data and how long for. But there are some easily implementable changes, like how many reformats we're storing. But I think this is somewhere where we would also really benefit from some specific guidance. So I think, sorry, I'm running over there because there's so much to say. My last slide is just an advert for the Green ID scheme, which is going to be launching hopefully in the next couple of months. We do have a dedicated session at the end of this series of talks, but I really would encourage everyone to try and engage with that. If you don't feel you're ready to apply for your department, it's also going to have a really website with lots and lots of resources, including links to these talks, but hope to build a lovely green community in Europe and beyond. Right, thank you very much.
Thank you so much, Sarah. That was just wonderful. Nice to set the scene with a broad overview. I really loved your slide where you demonstrated a little bit what the interventional radiology paper did with the, what's included in all of our calculations and where we can impact in radiology. And, so that's really, really helpful to kind of see a sort of overview like that. Thank you so much. And now we'll move on to our second talk. The idea in the sustainability ESOR course structure is that we start off with a lecture, and then this is followed by a case study about how, like a practical development at a department that somebody has undergone. And so we'll be hearing from Matthias. And then that will be followed by questions. So please do put any of your questions into the chat so that we can address them after Matthias's talk. So thank you. I hand over to you, Matthias, while you share your slides. Go ahead.
Thank you, Professor Rockel, for having me. Greetings, everyone. Just gonna put my slides on. So I have no conflict of interest. As Dr. Schurz said, sustainability in radiology gets up to multiple factors like patient transportation, paper usage, contrast agents management, waste management, and so on. And those are informations we start to know and we start to get in our everyday practice. However, what we must not forget is that this is a teamwork task. A radiology ward is not only the radiologists, it's also the rad techs, the secretaries, and we have to work all together in order to be more sustainable in the wards. For an example, here in Landerneau, when I took on the service, I created a small internal sustainability committee with one radiology technician, one secretary, and myself. And we are focused on analyzing our everyday practices and looking at how can we improve them. And once we decide on, for example, an idea, we then check further on if the idea was correct. If it doesn't change the workflow too much, and if the results are what we expected or not. We are collaborating with the hospital's sustainability committee, which I am also a member of. And for example, last year, we tried together to think, and we discovered that each patient that came to the hospital had a whole A4 paper sheet printed for just one sticker for each time he came to the hospital, because the hospital's logistics were like that. And it took quite a bit of discussion and thinking inside of the small committee in the radiology ward, but we managed to change the whole patient's secrets, so we don't have to print anymore those sheets and those stickers. We're also working on optimization of patients' planification and transportation. Like Dr. Schurtz said, patients' transportation accounts for a very big amount of carbon dioxide equivalents made by radiology, and we are synchronizing with the outpatients wards, being like, yeah, your patient needs a chest X-ray, so we're gonna do the chest X-ray, and then he'll go. He doesn't need to come a day earlier or a week earlier to get his chest X-ray. We can do it. We can do it on the moment, even if you add the patient extra. Or sometimes our patients need to have an ultrasound and chest X-ray, for an example. So we try to always put them together to make the patient come less to the hospital, which sounds kind of weird, but the idea is to just optimize the patient's secret inside of the hospital. We're doing this also with multiple exams being just held upon one day, with patient coming on the morning and going out at the end of the day, and all of the radiology exams that are needed are done during the day, so the patient doesn't have to come multiple times. And also, of course, there's everything about waste management or contrast management, for example. That's something we have to discuss with radiology technicians. It's not something a radiologist does by himself most of the time. So it's really important, I think, that we work all together in our wards to try to be more sustainable. Teamwork is also awareness raising. Interns, rad tech students, secretary, fellow radiologists. When I arrived in Landerneau, I took the time. I took half an hour with. It wasn't with each of them because I took them in a small group. But I just explained to them the sustainability in radiology, like the waste management, the energy consumption we're having, all about the contrast media, waste management, and so on. And I just realized most of them didn't know a lot, if anything, about that, because they were like 10 years after their studies, and 10 years ago we weren't talking about sustainability that much. So raising awareness around us in wards is a really important task for any of us, because, for example, now all of my rad techs are keeping the contrast media waste and getting it to be recycled, which they weren't doing earlier because nobody told them to, nobody explained to them why is it important to do it. And finally, and that's the point that can be the most particular when it comes to teamwork. Teamwork is the collaboration with the other doctors. As Dr. Shirt said, if an exam isn't done, then the whole impact and the whole carbon footprint of that exam doesn't exist. And in France, for an example, up to 30% of referrals in radiology are considered irrelevant. Being like sometimes a CT lumbar spine is asked for a patient with sciatica when it should be an MRI, or a CT scans being ordered when the simple ultrasonography could answer the question. Or even patients being hospitalized and having chest X-rays every 2 days because doctor deems it necessary to have a chest X-ray every 2 days, which are things we can discuss. And the world is knowing right now a permanent increase in demands in radiology. We are starting, it may be an understatement, but we are a major power of diagnosis, and every specialty in medicine needs a radiologist, needs imaging for the patients. So having good contacts and working together with the prescribers to diminish the number of irrelevant exams, of referrals that aren't that useful for the patient or even useless, which sometimes happens, could and will be a major task for every radiologist, I think, because we can try anything we want and everything we want to be more sustainable, to be more responsible, to take factors about sustainability into account. However, if the number of exams keeps increasing, and if those exams are irrelevant or useless for the patient, or not the best ones for the patients, needing extra exams and so on, as Dr. Short said, then whatever we are doing will probably, I think, be underwhelming in front of that increase in the number of exams we will be making. Thank you for your attention.
Thank you very, very much for your contribution, Matthias. And I think you and Sarah are very much in alignment. What I take away from your case presentation, Matthias, is that the way to get started is to develop a sustainability committee within your department. And we do have one direct question to you about this. How did you achieve to engage a team around the sustainability topic? And how did you bring people with you, develop the team, and what were the key messages that you started off with?
As I said, when I arrived in Landerneau, I really took it upon myself to inform and raise awareness inside my ward, to every rad tech, to every secretary, about the carbon footprint the service is having, which everyone was interested in, and as a lot of people were discovering those informations, because 10-15 years ago, nobody was talking about that, and especially in rad tech schools. Since my team is, I have a lot of younger secretaries and rad techs in my team, and sustainability is something that, at least in France, is very important in our everyday lives. So people were already aware of the importance of sustainability, but we didn't have the information, we didn't have the keys to put that into practice at work. And I allowed, well, maybe it's a hard term, but I allowed them to just put together all of the ideas, all of the thoughts, and to structure it in order to be not just ideas, but things we can do in
So
our everyday
actions,
practice.
actions, yeah. So one of the key actions that people can undertake straight away in departments is switching off machinery when not in use. So, for example, CT and MR scanners and PACS machines, even if you don't have automated systems, switching these machines off, we know from published work, saves a huge amount of energy, therefore carbon, but also saves a lot of money because of the reduction in electricity costs for the department. So my question to you is, did you have any pushback or concern from radiographers when you asked them to switch off? Or is everybody on board? Are there concerns or is there need for more training to allay fears about switching off the big equipment? Because sometimes people might feel it's the wrong thing to do or it might damage the equipment. And what is your experience? And then I'll ask Sarah the same thing. What is your experience in Brest about trying to get everyone to switch equipment off?
I wish it would be easier than it actually is because, for example, the MRI has the magnet that needs to be cooled down the whole time. So turning off an MRI usually icks the producers of the MRI who are like calling and the MRI is turned off. Are you sure everything is okay? We can't monitor the magnets temperature, maybe the MRI won't work. So we're not really helped by the industry for this one. And regarding the CT scan, the biggest concern was what happens when we're on shift? What happens when there's an emergency? Can we afford to wait to turn the CT scan on again just to perform a CT scan or not? And that is actually a good question because each CT scan has a different turning on time we discovered, and that's something that should be, I think, taken into account. Or, for example, in Brest, the university hospitals where I also work, we have 3 CT scans, so we're only using one for the night shift, and the other 2 are turned off. But it's complicated, and even when you manage to turn down the CT scan, the fellow radiologist tomorrow morning will be like, yes, but the CT scan is turned off. I will start late, I will end late. And there's a whole thing of patient secret and service workflow, ward workflow, in order to allow those switching the machines on and off here.
Yeah, so it was quite interesting. I had visitors in the department here at Imperial, and we walked around the department and just asked all the radiographers, what do you do at the end of the day? And I was expecting quite a few of them to say, well, we don't switch off. But actually, almost all of them said, oh, yes, we switch off. So even like the MR scanners and everything, I mean, they're switched off. I don't know exactly technically. Like there's obviously a mode, which is a switch off mode, which is safe and appropriate for the machine. So, I mean, I see that there's a real role for interaction with industry here to really help, with better idle modes and better booting up speed and things like that, but also to work with the radiographic team, the technical team, to really work through the benefits of switching off, the time frames and what it all means and the safety aspect and stuff, because I think we can save a lot of carbon doing that. And of course, with the heating and cooling, this is really important as well. But we need to get these things right and safe for the machines, absolutely. And as you say, if there's multiple machines for the on-call service, we maybe just need the one machine. We don't need 5 switched on. So that's again what we do at Imperial. We have the key machines for the nighttime work left on, and the cold work, that those machines are switched off when not in use. And Sarah, what's your experience trying to achieve switch off, and also for PACS and other machinery like printers and computers and things?
So, I mean, I think the main, I suppose, the main message is that communication is key, and you just have to start asking the question, because actually there are so many. If you're not sure if you can, you have, the medical physicists in your department usually who can probably answer that question very easily. Ask the service engineer when they come round to service the machine. And I mean, I think looking forward, I know that you and I are doing some work with some of the manufacturer sort of trade representation bodies, and they're really working on this on their end as well, and they're really interested in it. And I think where the ESR can really, and the Sustainability Committee can help us to sort of provide that link, and we talk about our user experience. And I think going forward, some of the sustainable procurement guidelines and things are actually asking for manufacturers to provide this sort of power efficiency and sort of switching on and off information as part of their, delivering new machinery and maintenance contracts. So hopefully it will become easier, but I would say, just ask someone. And like you say, just from your example, Professor Rockwell, walking around your own department and asking your radiographers, actually they're doing it already. And so to talk to each other, I think is really important.
Yeah.
So, but going on to PACS, I suppose we can talk about I think it's much easier. I think automation is going to be very important and a real friend to us to just make these things easier, because behaviour change is hard. It relies on individuals sort of continuing to sort of deliver the message. Our hospital had a very successful introduction of an automated sort of power switch off software for the trust, so for the whole hospital, for their computers, which I can't remember the exact figures, but basically it monitored the use of the computers in the hospital for about 2 weeks or a month, looked at the pattern of usage, looked at how many were just left idle, particularly overnight, and then was able to just automatically switch those off. I guess it's another example of this sort of myth of what you can do, because people always used to say, oh, don't switch the computers off because they need to do software updates. Whereas now we have this system where the IT department can remotely power them all back on for the software updates and switch them off again. And it's saving hundreds of thousands of pounds
I think in the first
power.
year, yes, I think in the
Yeah.
first year we saved something like 440,000.
Yeah, and it was
pounds
just when there was the sort of power crisis in Europe with the war, and so it suddenly even saved more than they'd anticipated. I think we did encounter a problem with PACS workstations because they were classified as clinical equipment, so they didn't automatically involve those. So again, we've had to do some specific work speaking with IT, but there's always a way if you find the right people to talk to, I think.
And I guess that's another thing that is quite interesting. Like Barry, we can talk about all the ideas, but it's what we want is implementation of the ideas. And one of the things I find, or I think could be quite motivating, is to demonstrate like the results. Like I think it's quite motivating for everybody to have seen that software that we put on the computers resulted in such a huge monetary saving for the department. And I just wonder, Matthias, do you measure, and I'm going to come back to some more of the questions in a minute, but just to finish this point, do you actually measure some of the changes? I have two questions actually. Do you measure some of the changes after you discuss, like, are there things that you've seen? Do you measure like at baseline, and then after you have a discussion and some education, do you see how things have changed in an audit scenario? Or because actually seeing the positive change can be quite motivating for people. And I wonder what you do in your department.
Yes, that's exactly what we're trying to do with our small committee. Once we implement a new idea, once we take a new action, we take up to 3 months sometimes to evaluate and see before and after. Sometimes the results are really, really obvious, if I can say. Like, for example, the paper sheet that was printed for each patient. Like, yeah, there were no more paper sheets. And we discovered, like, for example, one of our secretary is working half-time with the ER ward, and she didn't get the info, so she was still printing those papers. So that allows us to tell her, stop, you don't need to do it, everything's okay. We changed the patient secret, and even after, she started to do the same thing in the ER, and the ER now also doesn't print paper sheets for each patient. Regarding the contrast media management, the simplest example would be, we had I brought to Landerneau when I arrived a big plastic bottle for unused contrast media, and the bottle remained empty for a long time. And once we informed the rat techs about the importance of recycling, of recuperating the waste, and not throwing it down the sink or in the trash, the bottle filled up in 3 weeks. So
That's great.
we evaluate actions, and we often do feedback to the team to keep them motivated.
Yeah, I know, that's really fantastic. I think we have a whole session on contrast media waste, so I won't ask more about that just now, because I know we have a whole session. And I wanted to go to the next question, which was about patient travel. So it says, thanks for sharing the numbers on patient travel. What if we consider bloods, an aesthetic visit, pre-op visit, managed by the patient himself? I'm not quite sure what that means. Oh yes, so if the patient, perhaps what it means is if the patient chooses when they want to come for different tests, like the bloods and the ECG and the pre-op and everything like that. I mean, I guess, again, we probably need a lot of work with patient groups. But if people are made aware that each individual visit is carbon intensive, that may help. But my impression is that most patients, although probably we should do a survey, most patients would prefer to be able to come and have their ECG, their pre-op assessment, their chest x-ray or what have you with one visit, especially if they're working or if they have domestic caring responsibilities. Coming once would be quite nice. And mainly the problem is us being able to coordinate everything. I don't know what your thoughts are on the patient pathway, Sarah.
Yeah, I think this is a huge one. I mean, I must say, many hospitals managed to do it during the COVID pandemic, where we were trying to limit the amount of times patients had to travel. But obviously, generally, the amount of hospital activity was lower at the time because so many routine things were cancelled. It's such a big challenge because it really depends on the booking systems, what the waiting lists are like for different, and all these different departments, which are often run in very different ways. I did notice a question popped up below, so I'm just going to touch on that. Someone asking about AI. And I think, people get very excited about AI being able to read all the imaging studies, but actually it would be so much more useful if AI could do the booking system and make sure try and link these up. And also to look at the patient's imaging history. When I was talking about duplication, often patients have visited lots of different hospitals, and it's difficult to tell if they've had a study recently, which means they don't need to have the one that's being asked for now. So if we could use AI to help us with that information and to help us booking patients' tests, I think there's a big scope. But otherwise it's difficult because it's quite labor intensive, I think, to join up and communicate.
Yeah, and I think certainly in the NHS side, we're so pressurized with so many waiting lists that just fitting people in is quite tricky.
Yeah.
But definitely something for us to work on. I want to keep on moving through the questions because we've just got a few minutes left. So let's try and see if we can quick fire through some of the last questions. Thanks for the great content. Do you believe that dose image quality optimization on CT examinations should play a pivotal role in sustainability in radiology? So I guess this is another AI topic because we can really optimize dose and actually contrast dose as well. What do you think about that, both speakers? Quick fire answers.
Yeah, I'll really quickly say, I think we have to be careful because AI is very power hungry. But if we can reduce dose, that's potentially very beneficial. Like I said, the actual imaging equipment contribution to the overall big picture of our emissions is quite low. So maybe we shouldn't, it's not the first thing we should focus on, but there's a place for it. And I think reducing contrast use is important.
Matthias?
Yes, the dose and the energy consumption of a CT scan are mathematically linked one to another, which I mean, reducing the dose will reduce the energy consumption, and optimization of image quality and diminution of contrast dose, as Dr. Schrodt said, will certainly be useful. And those are questions we can ask for a PCCT, for an example, and not only AI.
Thank you very much. And we have another question. I feel nuclear medicine units have more challenges than others. To both speakers, please, do you have any advice for nuclear medicine staff seeking to improve sustainability? And I'm thinking of a very nice paper that was published by the group in Basel with their what do they call they demonstrate when the machines are on and off, and they demonstrate it in PET. So I don't know if you have anything to say about that, Sarah.
I can't quite remember. It's to do with the way they changed the
sort of dashboards,
for the patient moving through the department. Yes, the dashboards. I'm not too sure. I know that it's not an area of expertise. I know that the machine power consumption is different. I also know that in our nuclear medicine department, it had lots of sort of recycling issues with just the actual, lead-lined boxes that all the radiopharmaceuticals were delivered in, and they did a lot of work about sort of recycling those because there wasn't a facility available. But so there are people out there doing things, and I think possibly the nuclear medicine group will know a little bit more about that. But I know there are specific issues, and there are people who are exploring things. But
thank you for bringing that question up, because I think maybe we haven't focused on that in our sustainability subcommittee. Maybe we need to really build on that question and try and work further. I don't know, Matthias, if you have any experience with nuclear medicine in your department and sustainability issues.
Not yet, but we started last year. We started working last year with the nuclear medicine ward in order to actually assess their PET-CT energy consumption, because we have some of the newer ones, and we wanted to see if those are really that cost efficient as they are said to be. And since Doed Ben Salem is working a lot with contrast management, all of the contrast waste management for the CT part of the PET-CT, we are applying with them, and we're working with them in this. And to answer the question, I would say that without taking into account the nuclear waste of nuclear medicine ward, the way a nuclear medicine ward works is quite similar to that of a radiology ward. So a lot of the more generic topics that we'll be talking during these courses will probably be a lot of help, and can be good ideas.
And certainly PET-CT scans can be switched off. So that I do know.
Yes, we can.
And on that note, we're right at the end of our time. Thank you so much for all of your questions, everyone. Don't forget to do the evaluation so that you can get your CME certificate. I'm really grateful to you all for joining, and I hope you come and join the other talks across the year as we develop our toolkit. And if you want to join the Green ID scheme when it's finally launched after the pilot, we really look forward to your engagement around the world. We can see lots of people from all over the place. Thank you so much for joining us. Thank you to our speakers. So do you want to say anything, goodbye, or thank you, Sarah and Matthias?
Yeah, thank you so much for joining. I would just like to reiterate Matthias's point that start a group in your department. You'll be amazed how many people care about it and how much knowledge they have to share already. So team up. Yeah. Matthias, last words.
Last words, I say assisting lectures is always nice, but the main point is to get ideas and try to put them into action. So I wish everyone good luck with trying to be more sustainable.
Very good finishing words. So good luck with your sustainability changes in your own department, and thanks for joining us. Bye-bye, everyone.